This is the third lecture of the pathology of the blood and lymphatic. We will begin with aplastic anemia. Aplasia, it means non-production. A, when it comes before the word, it means the contrary, stop or none. So aplasia, non-production. So although it is called aplastic anemia, however, the entire bone marrow cells, they are absent. So it is caused by a damage to the multipotent myeloid stem cell in the bone marrow. So multipotent, it means the three cell lines, the myeloid, erythroid, and megakaryocytes are all absent, in contrast to the lymphoid, because the lymphoid cells come from a different stem cell. So the bone marrow becomes depleted of hematopoietic cells, and what remains is the fat. Patients will have peripheral blood pancytopenia. Pan, it means all. Cytopenia, all the cells are decreased except for the lymphocytes. In addition, they have low reticulocyte count. The pathogenesis of aplastic anemia, there is an extrinsic and intrinsic factor. The extrinsic factor, which is more obvious, the theory, it hypothesized that there is an antigen cross with the stem cells. So an activated T lymphocyte will destroy the stem cell because of that antigen. So that antigen seeds and binds the stem cell, and then the T lymphocyte identify the stem cell as a foreign and destroy it. This antigen, it can be a drug, it can be a virus, or even a virus particle, or other environmental factor. What is the base of this theory? That most of the patients, 70%, they gain the normal bone marrow again after they are given immune suppression, which suppress these T lymphocytes. Another thing, that 30% of cases of aplastic anemia, which is still a minority, the disease comes after an incident, after an obvious incident. One of the drugs that is notorious for causing aplastic anemia is the antibiotic chloramphenicol. Another drug is the gold injections, which were used for the treatment of rheumatoid arthritis. Non-steroidal anti-inflammatory drugs, sometimes in special people, they can develop aplastic anemia. It is not a side effect, instead it is an idiosyncratic reaction. Some people, they are minority, they do not know, and it is not something allergic. Instead, it has this theory that these cells might damage the stem cells indirectly. Sometimes in pregnancy, and some viral hepatitis are associated to or are known to cause aplastic anemia. However, most commonly it is idiopathic. There is no obvious cause. All of these factors are absent. This is around 60% of the cases, 60 to 70% of the cases are idiopathic. Another theory, there is an intrinsic factor. It is known that 10% of aplastic anemia patients, they have inherited mutations, inherited defects in the telomerase enzymes that give the stability of the chromosomes. So when they are defective, they do not work well, the chromosomes become unstable and they develop more mutations and die early. However, what is the explanation of the immune response to of the clinical response to immune suppression? That these defective stem cells, because they have defects in the telomerase, they might also have additional antigens that are abnormal, so the T cells identify them as foreign and destroy them. Patients with aplastic anemia, as we mentioned, they have pancytopenia. The 3 cell lines are down. They have anemia. Anemia is mainly normochromic. Sometimes it becomes macrocytic. Remember, we said problems with the stem cell usually give macrocytic anemia. They also have leukopenia. The white blood cells are below the normal, and thrombocytopenia. In the bone marrow, there is markedly decreased hematopoietic cells, and there is only residual fat. This is a comparison on the left, the aplastic anemia bone marrow. As you see, it is mostly fat, and the residual cells, they are very minor hematopoietic cells, and most of them are lymphocytes, which are commonly not affected by the aplastic anemia. This is in comparison on the right to the normal bone marrow. Aplastic anemia can be critical because patients with leukopenia, they might develop severe infections and die of it, or even a major bleeding because they have thrombocytopenia. So it is considered as an emergency and it needs immediate intervention. There are special types. The first one is called Fanconi anemia. Fanconi anemia is very rare. It is an inherited form of aplastic anemia. So it manifests early in life, during infancy and childhood. In this one, there is a defect in the DNA repair proteins. Okay, the repair proteins are defective, mutant, so the patients will develop cumulative mutations, many mutations after that. So the bone marrow might develop aplastic anemia, the full-blown one, or even they turn into acute leukemia because of these mutations. Another disease, it is different from aplastic anemia, but there is a similarity that the problem manifests in the bone marrow. It's called pure red cell aplasia. So from the name, the problem is only in the erythroid cells. The patients have anemia, okay, similar to aplastic anemia, but the white blood cells and the thrombocytes or the platelets are normal. If we take a biopsy from the bone marrow, we see only absent erythroid cells, nucleated RBCs. They are absent, okay, while the myeloid and megakaryocytes are intact. They do not have a problem. Pure red cell aplasia, it is generally less common than aplastic anemia. It can be congenital early in life, and this is called Diamond-Blackfan anemia. Or more common, it is an acquired form. This one is seen in autoimmune diseases like systemic lupus erythematosus or rheumatoid arthritis. Okay, so it has an autoimmune reaction against the erythroid cells in the bone marrow, or sometimes after parvovirus B19 infection, which targets the earliest normoblasts. Symptoms, usually it is insidious but can be accelerated. The main symptom is anemia. Patients also develop thrombocytopenia, so they have bleeding similar to aplastic anemia, and also have neutropenia, so they have pancytopenia similar to aplastic anemia, and it can be fatal secondary to serious infections. Next, we have anemia of renal disease. As we mentioned earlier, the kidneys are the major site for production and synthesis and production of erythropoietin. So in kidney diseases in general, there is a deficiency in the function of the kidney, and thus erythropoietin is not produced in a normal way and not in an enough amount. So the patients will have decreased production of RBCs from the bone marrow. Usually there is no correlation between the erythropoietin, the amount that is secreted, and the kidney function when it is deteriorated. Some patients, how do we know that the patient is not functioning? By the test, we have the serum creatinine level. If it is increased, this means it cannot be excreted outside the body, and this means that the kidneys are failing. So if we have high creatinine, this means the patient has renal disease. Okay, so about this sentence, sometimes the creatinine the increase of creatine is only moderate. However, the patient might have severe anemia because there is no correlation between the creatinine and the degree of the diseased kidneys. So we have decreased RBC production. The patient will have anemia and low retic count. In advanced kidney diseases, in chronic renal failure, there is a clinical situation called uremia. Okay, increased the urea nitrogen in the blood. When it is severely increased and on a long term of time, the patient will have a special condition called uremia. In uremic patients, they have abnormal platelet function because these urea, they change the environment, the normal environment of the blood. So the platelets, they become non-functioning, although the count is normal. If you test the patient, he has a normal platelet count, but these platelets are not functioning, so they develop bleeding and then anemia secondary to bleeding. There is also a special morphology of the RBCs in uremic patient. We call it echinocyte. The other name is Burr cells. So they appear as having all over notches and projections around the cell membrane. بالعربي الخلايا الشوكية. Okay, they have small projections all over the cell membrane. This is again secondary to the increased urea in the blood. So this is about anemia of renal disease. Anemia of liver disease. This is not a special type, but patients with liver disease, they commonly have anemia. It is multifactorial. Multiple factors can cause the anemia. There is decreased synthesis of clotting factors, so the patient doesn't have normal hemostasis. If he has any injury to the blood vessels, they keep bleeding, and this causes anemia. Patients commonly also have varices. Varices are large tortuous veins in the GI system. Okay, they appear between the esophagus and the stomach, and also around between the rectum and the anus. So these sites, they are vulnerable to bleeding. Patients with liver disease, they commonly have varices and multiple bleedings. There is also decreased synthesis of transferrin, as we mentioned earlier, and patients will develop anemia. What about the special morphology? Sometimes patients have acanthocytes. Acantho, again, it has the projection, but they tend to be longer and larger than in the echinocyte. You see all of these RBCs with abnormal shape. These are acanthocyte or spur cells, so they appear in liver disease. Sometimes they look very similar to the echinocytes, so both of them, they are a continuum to each other. Why do they appear? It is not fully known, but there is a theory that patients with liver disease, they have abnormal metabolism of the lipid. So the cell membranes which contain lipid, they might be affected, and they have a change in their normal constituents and thus their normal morphology. Anemia of hypothyroidism. Hypothyroidism is a relatively common disease. Thyroid hormones, they are important for keeping the metabolism of all cells in the body, and one of them are the bone marrow cells. So thyroid hormones, they stimulate erythropoiesis, and when they are deficient, they cause decreased erythropoiesis. Patients will have anemia. Mostly it is normochromic, but sometimes it is macrocytic. This is important to remember. macrocytic anemia, one of the causes is hypothyroidism. Okay, we took megaloblastic anemia, also aplastic anemia can be macrocytic, and now hypothyroidism. Myelodysplastic syndrome, this is an acquired disease and relatively it is a common one. It is primarily a disease of old people, okay, and it is a neoplastic disease. Patients will have multiple mutations in the bone marrow stem cells. They have a prolonged survival but abnormal maturation. Okay, this is the hallmark of myelodysplastic syndrome. The bone marrow is full of cells because they are prolonged in their survival, but they cannot function well. So most patients will have anemia. We will discuss it later on within the myeloid neoplasms, but I mentioned it here to remember it as one of the causes of anemia of decreased production. Okay, it is the only neoplastic one that we have talked about till now. Most patients will have anemia, and because it is neoplastic, it is refractory to treatment, which means if you try to give the patient iron, it doesn't respond. If you give him or her folate or vitamin B12 or erythropoietin, they do not respond because the stem cell is mutant. This is another disease that causes macrocytic anemia. Remember, the defect is in the stem cell. Now we finished the first category, which is anemia of decreased production, and now we move to the second category, which is hemolytic anemia. Hemolytic anemia, simply the problem is in the survival of the RBCs. Normally, the lifespan is around 120 days. In hemolytic anemia, they survive much less than this number. So the patient will have hypoxia, which triggers the release of erythropoietin. It causes compensatory hyperplasia of erythroid cell in the bone marrow, and the patient will have reticulocytosis. So this is a hallmark difference between hemolytic anemia and anemia of decreased production. In this one, we have reticulocytosis. The percentage of reticulocyte in the peripheral blood is above, and it is high. It is above the normal. In severe cases, as we mentioned earlier, if erythropoietin is very high and persistent for a long time, the patient will develop extramedullary hematopoiesis. Okay, there is production of blood cells from the spleen and the liver. So the patient will have hepatosplenomegaly, enlarged spleen and liver. Another feature of hemolytic anemia is the development of jaundice. Hemoglobin is released from the damaged RBCs. Because the RBCs are torn, they are broken, so the content goes out. And we will talk about this in details. So the RBC, it is released, hemoglobin is released from the RBCs. And one of the tests that is useful in diagnosing hemolytic anemia is to measure haptoglobin. Hapto, it means liver, so this protein, it is synthesized from the liver. Okay, and this one, it binds the free hemoglobin. After it is released from the RBC, it binds this hemoglobin. So if we measure haptoglobin and it is decreased or absent, this means that hemoglobin consumed or haptoglobin, and thus the patient have hemolytic anemia. So haptoglobin is decreased in hemolytic anemia. The free hemoglobin is toxic. It is injurious. It causes injury to the tissue. So this is why we have haptoglobin. Classification of hemolytic anemia. In the pathogenesis, it is important to know where is the site of hemolysis. The most commonly, it occurs outside the blood vessels. It occurs in the spleen, the main site of hemolysis. So we call it extravascular hemolytic anemia, which is the most common form. The RBCs are taken by the macrophages in the spleen and they are destroyed. This occurs if the RBC has abnormal shape or it is coated with antibodies, and we will talk about them later on. They are removed by the macrophages and the patient thus have jaundice because hemoglobin is metabolized there and turned into bilirubin. So bilirubin will cause jaundice and also pigmented gallbladder stone, and the final symptom is splenomegaly. In contrast, sometimes the hemolysis occurs inside the blood vessels within the mainstream of the blood. This one usually there is a sudden hemolysis. The release of hemoglobin comes abrupt, all of a sudden and in large amounts, so this form is more critical than the first one. Patients will have hemoglobinemia, which is the free hemoglobin. As we mentioned, it binds the haptoglobin, but sometimes all the haptoglobin is consumed and we have still more hemoglobin, so it causes damage to the tissues. Hemoglobinuria, okay, it is secreted in the urine, so the patient will have a red urine at the time of hemolysis. Hemosideриnuria and iron deficiency, because along with the hemoglobin there is iron, so it is excreted with hemoglobin in the urine and the patient will develop iron deficiency. So in this form, it is more acute and more critical symptoms, and the haptoglobin is almost absent in contrast to the first one because it occurs outside the blood vessels. Now, according to the cause of hemolysis, we can classify it, as we mentioned earlier, extrinsic or intrinsic, or in another term, extracorpuscular. It means outside the RBC, and we mentioned this as microorganisms like malaria, antibodies that come against the RBCs. Sometimes it is intracorpuscular, like in enzymatic deficiencies, like in thalassemia or other diseases we will talk about. Okay, we'll begin with thalassemia. It is the most important hemolytic disease. It is very common in our region. Okay, thalassemia is not a single disease. It's a group of inherited disorders that result, all of them, they share the same phenomena. There is a decrease in the production of either alpha or beta chains of the hemoglobin, or sometimes rarely both of them. Okay, so if the patient has decrease in the alpha chain, we call it alpha thalassemia. If he or she has decreased production of beta, then it is a beta thalassemia. So the total amount of hemoglobin is below the normal. And there is another problem, because during transcription of the DNA, one of them is produced in a normal amount while the second one has a shortened or decreased amount. So at the end we have an extra chains of the normal one. These extra chains can cause hemolysis, because if they are unpaired, they remain in the cytoplasm, they can cause physical damage to the RBC and hemolysis. So this is why thalassemia is classified as a hemolytic anemia. Okay, in addition to the decreased hemoglobin production, they also have hemolysis. Thalassemia is an autosomal recessive disease. So one of the patients, one of the parents is a carrier, or both of them as a carrier. We will talk about it. And it is common in the old world countries, like in the Middle East, Africa, and Southeast Asia. It is less common in the Western countries. For unknown reason, malaria falciparum, it doesn't like any abnormal hemoglobin. So one of them is thalassemia, and we will talk about sickle cell anemia later on. These patients, they do not develop infection by malaria falciparum. Physiologically, the normal hemoglobin in any RBC, it consists of, most commonly we have the hemoglobin A, more than 95% of the total hemoglobin inside the RBC is the adult hemoglobin A, which consists of 2 alpha and 2 beta. And this is the mostly affected one in thalassemia. The second most common is adult 2, A2, consists of 2 alpha and 2 delta. Okay, and it is important for diagnosis in beta thalassemia. The least common one is hemoglobin F, 2 alpha and 2 gamma. Hemoglobin F is present normally in the adults, the least common one. Sometimes there is variation between adults, sometimes it becomes increased, and this is normal inheritance. Okay, but this one is important. This one is the most common in the newborns and in the first 6 months of life. The alpha chain is encoded by 2 genes on chromosome 16. Okay, we have 2 genes, so the total is 4, if 2 paternal and 2 maternal. So mutations that causes alpha thalassemia, most commonly they are deletion. We have a deletion in the genes of alpha thalassemia. Now if there is a deletion of a single gene or 2 genes, still we have extra genes that are functioning. Okay, we have 2 or 3 genes that are still functioning, so the patient will have be either only a silent carrier or very, very minor symptoms. Okay, so deletion of 1 or 2 genes in alpha doesn't cause a clinical disease. Instead, the patient becomes a carrier and he can transmit the disease to the next generation. Deletion of 4 genes, it is incompatible with life. Okay, because the patient will not have either the adult hemoglobin, hemoglobin A, hemoglobin A2, or hemoglobin F. They are all absent because all of them need alpha chain. So these patients, they die early inside the uterus or shortly after birth. We call it hydrops fetalis. Hydrops fetalis. If there is deletion of 3 genes, this means there is only 1 gene that is functioning, and then the patient will have decreased amount of hemoglobin A because we have extra beta and the patient doesn't have enough alpha. So this will manifest as a clinical disease. Patients will have symptoms of anemia. It is lifelong, and we call it hemoglobin H disease. Hemoglobin H disease. Remember, H, it has 3 lines, so there is 3 deletion in the alpha chromosome. And these patients have a lifelong thalassemia, as we mentioned. Now, for the extra beta chains, they bind to each other and they form a tetramer. Okay, it forms like a hemoglobin, and we call it hemoglobin H. This is why the disease is called hemoglobin H. So hemoglobin H, it consists of 4 beta chains. They function. They can bind oxygen and deliver it to the tissue. Although it has a high affinity to oxygen, but it is still functioning. There is also an extra gamma. Remember, every transcription of DNA, it will produce the normal amount of delta, gamma, and beta, while alpha is short of them. So the tetra gamma is called hemoglobin Bart's. Okay, so in hemoglobin H disease, we have the patient have hemoglobin H, also hemoglobin Bart's. Bart's consists of 4 axon. B is not beta, B is gamma. So tetra gamma gives Bart's, tetra beta gives H. So these patients have lifelong anemia, but they are compatible with life. For beta thalassemia, the beta chain is encoded only by a single gene, which is located on chromosome 11. So that every human has 2 sets of genes. Most of the mutations in the beta thalassemia, they are point mutation. Okay, not deletion like in alpha. It is only point mutation. So we have so many types of beta thalassemia because every mutation gives a certain degree of deficiency and it alters the function of the gene differently. There are more than 100 types of mutations in beta thalassemia. Now, in general, if there is no production at all in the gene, we call it beta 0. Okay, if this mutation causing non-functioning gene at all, so that set of gene doesn't produce any beta chain, it is beta 0. Other mutations, there is a production of a smaller amount of beta chain, so we call it beta plus. Okay, there is production, but it is slow and decreased. Now, when combination from maternal and paternal, if one of them is normal and the second one is plus, the patient either is a silent carrier, okay, or he or she has very mild anemia. And these carriers, we can test them before marriage. In contrast, we'll go to the severe one. If there is beta 0, both of them, the maternal and paternal, or sometimes beta 0 with beta plus, and this plus, it gives very small amount, only very small amount of beta chain. We call this thalassemia major. Okay, and there is another name is Cooley's anemia. Cooley's anemia. Okay, thalassemia major. This is the most serious one in all thalassemias. There is a thalassemia intermedia, which has a moderate symptoms. Okay, and commonly we have beta plus from each side. Now, if you go to the textbook, you find different combinations. Okay, it doesn't match always with each other between the intermediate and the major. Sometimes plus plus, but they are major because every mutation is dramatic and doesn't produce enough hemoglobin. Okay, but this is to remember as a concept. Thalassemia major, there is a markedly, there is either completely absent beta or very small amount. Remember, we have more than 100 mutations, so there is a map. Every patient, we make DNA study and we can see in which category he or she falls. Now, what worsens beta thalassemia, what makes it worse than alpha? In beta thalassemia, the extra or the excess alpha chains, they cannot bind to each other, as what happened in the hemoglobin H and BART. They remain in the cytoplasm uncoupled, so at the end they cause a solid particle inside the cytoplasm and cause hemolysis of RBCs and even the precursors inside the cytoplasm. So we have early hemolysis, as we mentioned in MYELODYSPLASTIC anemia, but in this one it is more serious because every RBC has this problem, and this makes beta thalassemia in general has worse symptoms than alpha thalassemia because the extra alpha, they do not bind to each other, they do not form hemoglobin, so they cause hemolysis inside the bone marrow. Morphology, we have a short amount of hemoglobin, so it is like the iron deficiency anemia. We have hypochromic microcytic anemia. Target cells appear again because we have abnormal hemoglobinization in each RBC. There is a peculiar feature, we call it basophilic stippling. Basophilic, it means blue line, blue color. Stippling, it means small dots. Okay, small dots. These are remnants of the ribosomes or RNA from the nucleated RBC. They still appear in the cytoplasm as small blue dots. Okay, it appears in thalassemia, but in other diseases can appear, but most notoriously to take place in thalassemia. We have reticulocytosis, as we mentioned. This is a main difference between thalassemia and iron deficiency anemia. Now, in thalassemia major or Cooley anemia, RBCs will become poikilocytotic, like in iron deficiency anemia. We see different shapes and figures. We also see nucleated RBCs because they have enormous number of them in the bone marrow, but they cannot compensate for the anemia. We have very large number of nucleated RBCs in the bone marrow, so they can disseminate also in the peripheral blood. So this occurs only in thalassemia major. If we take a biopsy from the bone marrow, we see very large number of erythroid cells, nucleated RBCs or normoblast. They are markedly increased. Why? Because of the effect of erythropoietin. They fill the bone marrow spaces, they expand into the bone itself. Okay, it can steal the oxygen from the bone. Okay, so the patient, as we mentioned, will have abnormal bone growth. The bone marrow spaces also, they are expanded in patients with thalassemia. If you look at the face, as we mentioned, they have deformities. The bone appears enlarged, thick, and it is full of blood. Even if they take an X-ray, the shadow of the bone marrow will appear in the X-ray film. Hemosiderosis is a major and important complication of thalassemia major. Hemosiderosis, okay. Hemolysis بطلع لنا iron, okay. The high erythropoietin, as we mentioned, which is lifelong. Erythropoietin is an antagonist to the hepcidin. So hepcidin is low in patients with thalassemia, so it doesn't inhibit the iron absorption. Instead, the patients will keep absorbing iron from the gut, and this will result in hemosiderosis. Also, patients with thalassemia major, the usual treatment is blood transfusion. You cannot correct the anemia because it is inherited. So usually patients, they receive blood transfusion when they have major symptoms. So this will give them another amount of iron each time. So hemosiderosis, it appears in the bone marrow, and if it is not treated, it will accumulate in all organs of the body, and it is a fatal complication. So this is a peripheral blood on the left from a patient with thalassemia. As you can see, we see target cells, okay, and you can see the small blue dots in many of the RBCs, and the arrows and the letter B, they all indicate the basophilic stippling that we mentioned. Okay, and there is a nucleated RBC also can appear in the peripheral blood. On the right side, the above picture is taken from the bone marrow. As you see, most of the cells, they are normoblast. This is secondary to activation of erythropoietin. The normal bone marrow, the myeloid cells, they are more common. They are excess. Okay, they are 3 to 4 times more common than the normoblast. While in this picture, the normoblast, they are the dominant ones. This means the patient has marked erythropoiesis. And on the right below picture, you can identify it as the Pearl's stain. This is iron. As you can see, it fills the entire bone marrow particle. It is very thick iron, okay, and you can see it from very low power. So this means that the iron is increased and the patient has hemosiderosis in the bone. Clinically, patients with thalassemia trait carriers, they are asymptomatic at all. They have normal lifespan, okay, but you can detect the abnormality if you do the complete blood count test, okay. The RBCs, they are hypochromic, microcytic, but in a mild degree, okay, and this is what we do in the premarital test regularly in Jordan. Every patient has, every candidate for the marriage, both of them, the couples, they make test for the mean cell volume of the blood of the RBCs, and if it is below the normal, this means it can be, as we mentioned, iron deficiency, which is the most common, but it can be also thalassemia. So they have to do another test. We will talk about it in a moment. In thalassemia major, which is Cooley anemia, beta thalassemia major, symptoms begin after the age of 6 months. okay, during infancy. In the first 6 months, the dominant hemoglobin is F, okay, it doesn't have beta. So hemoglobin F still makes the function of hemoglobin, while it keeps its level, normal level, keeps going down until the age of 6 months, when hemoglobin A becomes the dominant one. So at that time, the patient will start developing the symptoms of anemia. So they have persistent, lifelong symptoms of anemia that we mentioned earlier. They also have growth retardation, skeletal abnormalities, which can be decreased, ameliorated, مخففة, by giving regular blood transfusion to the patient. What is the problem with transfusion is the iron. Remember, we mentioned that a human cannot excrete iron. Okay, so if you take it in the body, you have to lose it in a physical way. So systemic hemochromatosis or secondary hemochromatosis can develop, and usually in the second or third decade of life, and at that time the patient will die. The problem with iron, or the hemosiderin, large particles of hemosiderin, it causes physical damage to the organ. Okay, so it can infiltrate all organs in the body, like the heart, and it causes heart failure and then death. It also can causes a damage to the endocrine system, and many of them are crucial and essential for our life, like the pituitary gland. If it is damaged, then the patient will die. So this is about beta thalassemia major. In alpha thalassemia intermediate, اللي هي hemoglobin H disease, as we mentioned, the symptoms are intermediate. Patients will have a lifelong anemia, but they do not need blood transfusion. The degree of anemia is much less than in thalassemia major. And recently, one of the options to treat them, but it is still in research, not in the clinical practice, is to give bone marrow transplant. Okay, you give a new stem cell that can populate and correct the disease. How do we diagnose thalassemia? As we mentioned, we have the blood film, we have the clinical picture, but the most important one in diagnosis, we call it hemoglobin electrophoresis test. Electrophoresis, from its name, we give, this is a machine, it's a device. The principle is to give electric current to the hemoglobin, so it separates the particle, the chains, into alpha, beta, gamma, all of them. And the test, the device can give you the percentage of each type of hemoglobin. Now, in all types of beta thalassemia, there is an increase in hemoglobin A2. Okay, beta, we have shortage of beta chain. Hemoglobin A2, we do not have beta chain. Instead, we have delta. So the extra alpha binds extra delta. So hemoglobin A2 is increased. Okay, normally in most of the adults, hemoglobin A2 is not more than 3% of the entire hemoglobin. If it is increased above this, احنا عندنا في الجهاز around 3.5, the upper limit. If it is more than this, then the patient has beta thalassemia. Simple diagnosis. Hemoglobin F also increases, okay, but hemoglobin F is much variable between adults. Hemoglobin A2 is more consistent. Hemoglobin F, some people, they normally have a high amount of hemoglobin F, maybe 10%, 15%. This is a normal variation between individuals, but in general it can be increased in beta thalassemia. So increased hemoglobin A2, it means patient have beta thalassemia. In beta thalassemia major, as we mentioned, beta 0, there is no hemoglobin A. Adult hemoglobin is totally absent. What about alpha thalassemia? If the patient has hemoglobin H disease, as we mentioned, these tetra beta or tetra gamma, hemoglobin H and hemoglobin parts, they appear in the test, so it can give you the diagnosis. While in the carrier of alpha thalassemia, there is no abnormality can be detected in this test. Why? Because there is a decrease in the alpha, so there is an equal decrease in hemoglobin A, hemoglobin A2, and hemoglobin F. All of them are decreased, but the percentage will stay the same. So we cannot diagnose the alpha carrier. هدول كيف نعرفهم؟ بيجي البيشنت عنده mild hypochromia, mild microcytosis. Okay, we do the electrophoresis test, it is normal. We do the iron test, it is normal. So we suspect in her alpha thalassemia. At that time we do DNA test. Okay, we have genetic testing is available now for the alpha thalassemia. In the previous days it is diagnosed by exclusion. Patient has normal iron and normal hemoglobin A2, so this means it is alpha thalassemia. Okay, this in this picture on the left side, this is the hemoglobin electrophoresis test we talked about, and in the left side, as you see, there is a big band. هاي هي عبارة عن الهيموغلوبين A. It is the most common one. Okay, hemoglobin F مكتوبة, and there is a small band of hemoglobin A2, and that device gives you the percentage of each one. As you can see in the red line, the red arrow, hemoglobin A2, the percentage is 4.9, which is above the normal. Okay, 4.9 معناها هذا البيشنت عنده beta thalassemia. On the right side, another test. This is hemoglobin H disease. As you can see, the biggest one is hemoglobin A, adult hemoglobin, but on the far left side of the test you can see two bands, they appear. One of them is the hemoglobin H and the other one is hemoglobin BART. Actually the machine, it gives you the exact location of each band. هو بعطيك percentage and it tells you that this is the location of hemoglobin H, this is the location of the hemoglobin BART, and this is the percentage of each of one. So you have to make only the diagnosis of hemoglobin H disease. If these both are absent, okay, and the hemoglobin A2 is below 3.5%, then the patient is either normal or have alpha thalassemia.